All right, so let's go ahead and get started. Thank you guys for joining us on our COVID-19 Preparedness Echo Lecture Series. Tonight is the first one. We're going to be doing an overview of COVID-19, as well as diagnosis, infection prevention, proper PPE use, and that will be given by Dr. Bridget Hurry. And then after that, we're going to hear a little bit from Jose Laguna. He's an ICU nurse from Spain who he's going to share with us his experience learning how to handle COVID-19 in the hospitals. And before we get started, though, I'm going to hand it over to Monica real fast.
Hi, everybody. Monica Kainer here with Assist International. I just wanted to thank all of you for joining, and in particular, our interpreters and everyone who made this possible today, including the GE Foundation and David Barish in particular, Project Echo headquarters, who this is all made possible through, Cambodia Ministry of Health and our other partners there on the ground, as well as other partners we work with in a variety of countries in Southeast Asia. We're really excited to start this lecture series, and it will be happening on a weekly basis. So we're very excited about that. I'm now going to pass it along to my colleague Vaughn Williams to start the presentation.
Hi everybody, I'm Vaughn, and I just want to touch really quick on the echo etiquette that we hold to try and keep a collaborative atmosphere. I'd like to emphasize that the foundation of everything that we do here is love and respect, that we're all trying to learn and work together to provide the best care that we can to patients across the world. So everybody, we rely on you to keep this a safe space for learning and collaboration. We ask that you try and test your equipment ahead of time just so that we can have even flow, and when we get to the Q&A session and you'll have the opportunity to ask questions, that you introduce yourself before speaking. Just be mindful of what you're doing on screen because everybody can see you. And if you can, avoid making noise, eating potato chips, that sort of stuff. It can be distracting when the lecture is being given. And it's best in general to just keep things on mute. You can find the mute button in the bottom left-hand corner. So when you're not speaking, just use that. And then when you go to speak, just remember to unmute before you do so. Try and position your webcam effectively to show your face, and have a light source if you can, showing in the front so you're not in shadow. Again, try and test the audio and video before we start, and when you're speaking, try and speak close to your microphone. Should you have any IT issues, just send a message through the chat. That should be it. So, Monica?
I think we will pass it along now to Dr. Bridget Hurry to start the presentation. Thank you.
Thank you, Monica, and thank you everyone that has joined us here today. My name is Dr. Bridget Hurry. I am, Chase, going to use your version because I can't seem to get it to share. But I am just so appreciative of Assist International and Echo to allow us all to get together. We can learn from each other's collaborative minds and experiences and walk through this pandemic with better, you can go back just one if you want, with better preparedness. So our learning objectives for today will be to understand the basic principles of COVID-19 disease diagnosis, the basic principles for infection prevention and control, as well as understanding the proper technique for using personal protective equipment, which we'll refer to as PPE throughout the course of this presentation. Again, my name is Dr. Bridget Hurry, and I'm with Jose Laguna, and we will be available for questions at the end of this presentation, so please just hold that and we'll be ready at the end of this presentation for plenty of questions and answers.
You could choose. If you would like to type your questions in the chat box. We'll also be monitoring that as well.
Thank you. So just a brief overview. COVID-19 is the name of a novel coronavirus that is a positive strand RNA virus that was first discovered after a cluster of patients were found to have disease in Wuhan, China. As of March of 2020, the WHO declared this COVID-19 clinical situation as a pandemic. Currently, we have over 1 million confirmed cases. We have 82,000 deaths. And over 184 countries and regions have been known to be involved. COVID-19 is the name given for this virus, and the disease presentation has been given a name called SARS-CoV-2. The clinical manifestations of a patient with COVID-19 has an array of manifestations, with the largest being mild disease. You can go ahead and change it forward. Thank you. 81% of patients will have a mild upper respiratory illness. Most of the presenting features have been found to be fever, cough, and shortness of breath. There have been other reported mild symptoms such as sore throat, gastrointestinal problems like diarrhea or vomiting, as well as unexplained loss of taste or smell. You can go back real quick. While 81% of patients will present with a mild presentation, 14% will present with a severe manifestation, and the clinical presentation for them, severe disease, is a clinical pneumonia. 5% of patients will present with a critical disease, and that is septic shock or respiratory failure. And of note, up to 1% of patients have been found to present with asymptomatology. So they will have no clinical features suggesting COVID-19 infection or conversion. You can go ahead and change slides. From our current studies of the COVID-19 pandemic, the mean incubation or the median incubation period is 4 to 5 days. Most patients presenting with illness by 14 days. From our studies out of the initial patients out of Wuhan, China, we have found there to be a median age of the late 40s, early 50s, closest to 47 years of age. And we know that men are more susceptible to the disease than women. We currently know that there are droplet forms of transmission, and most droplets cannot transmit farther than 2 meters or 6 feet. And that distance will come into play when we talk about prevention of transmission. There's also been documented forms of contact transmission. So you'll hear us talk about disinfecting frequently contacted surfaces. And there is suspicion for airborne transmission. It's of note that the viral loads are noted to be highest in the initial days of disease progression, and we have found viral loads high in asymptomatic patients, which is suggesting that patients could be infectious even prior to symptoms being clinically presented. Go ahead. Out of a study of Wuhan population patients that were hospitalized with pneumonia, we found at admission there was lymphocytopenia, thrombocytopenia, as well as
Những cái kết
leukopenia.
quả từ phòng lab cho thấy là có
Some
cái
patients
giảm
were
tế
also
bào,
noted
giảm
to have
bạch cầu,
elevated liver
như là
enzymes.
giảm bạch cầu, tăng men gan.
With imaging, the classic
Đối
findings that
với
we have appreciated are ground glass
chụp
opacities,
CT
as
thì
well as
chúng ta
multiple
thấy thường gặp những tổn thương tính
consolidations
mờ
on a COVID positive patient's
trong
chest
những bệnh nhân mà
CT.
dương tính với COVID.
And on
19.
X-ray, we can expect to
Đối
see
với
peripheral
X-quang thì
distribution
ta
that is usually
thường
bilateral and usually involves the lower lobes.
sẽ thấy những cái tổn thương ở thùy phổi phía bên dưới, tổn thương phía bên ngoài
Diagnosis for COVID-19.
và ở cả hai bên.
The key for our
Đối với việc chẩn đoán,
ability to transect the continuation of the COVID-19 pandemic will start at our initial
làm thế nào để có
efforts
thể chặn được
and
dịch bệnh này thì
effective
đều phải bắt đầu
implementation
từ
of
việc
screening.
sàng lọc. Chúng ta sẽ phải
At a
sàng lọc tất cả
minimum,
bệnh nhân
we
khi
need
bắt
to
đầu cơ
screen
sở.
every
y tế,
patient at their
tất cả
first
các bệnh nhân.
contact with the healthcare system.
Tôi xin
Screening
nhắc lại
currently involves asking specifically about symptoms
và
such as
bao gồm
fever,
cái việc là sẽ phải hỏi
cough,
tất cả những cái triệu
or
chứng
shortness of breath.
có, ví dụ như ho.
Asking specifically about any known
Hỏi
contact
rất là
with a
kỹ
known
về
or
những
presumed
người mà họ
COVID-19
những người
infected
mà
person,
dương tính với COVID-19,
and also asking
cũng như
every
những người
patient
mà
about
nghi
travel to
là
any
dương tính với
reported
COVID,
area of COVID disease
những người đã
transmission.
từng đến những vùng
In
nóng của
some
dịch.
more developed countries, temperature measurement is recommended, and that would be at the first point of contact with all patients. For any patient that screens positive to this preliminary question taking and potential temperature objective report should be given a mask and kept a desire of 2 meters, which is 6 feet away from other persons. The minimum should be 1 meter if the area is constricted. And from that point on, all healthcare personnel should wear personal protective equipment, PPE, when evaluating these positively screened patients.
Khi mà tiếp tục khám cho những cái người dương tính.
On this slide, and we can make our PowerPoint slides available based on Assist International's copyright. I wanted to point out that the recommendations for most disease cases is self-isolation. So home, self-isolation. That will look like having the patient stay at home containment. Another point of this slide I wanted to point out is that there are some risk factors that we know are comorbidities for patients at risk for COVID-19 infection, and that includes advanced age, cardiovascular disease such as hypertension, chronic renal disease, cancer, or other immunocompromising conditions. And so for these patients, we need to have a heightened level of suspicion for the possibility of a COVID-19 infection. Go ahead. Thank you, Chase. Currently, this WHO is recommending, or the CDC is recommending, nasopharyngeal and oral pharyngeal swabbing. With these swabs, a real-time reverse transcription polymerase chain reaction, or PCR assay, are run on these collected respiratory specimens. It is recommended to not induce a cough to get deeper sputum for the risk of transmission.
Hiện giờ đối với COVID-19
And if you were to visit the WHO website, they currently have a list of reference laboratories available for this PCR confirmatory testing. If COVID-19 testing is unavailable in your country of origin, but please note there are special instructions for documentation and shipping of these respiratory specimens.
Chúng tôi cũng sẽ đưa ra cái danh sách này ở trong slide để những cái
If we have the testing to collect a nasopharyngeal specimen, it is of note that you should have the patient blow their nose and tilt their head back slightly. Asking the patient to close their eyes can help alleviate some discomfort with the test specimen collection. Then you gently insert the swab close to the nasal septum, just above the nasal floor, until resistance is met. You rotate the swab for a full 10 to 15 seconds, and then immediately remove the swab and place it and cap it in the nasopharyngeal specimen container.
vào trong cái hộp đựng mẫu.
For infection prevention, we can move into that. The key, I think we skipped one slide. Just go back one. Oh, I guess not. It's not there. That's okay. The key will be hand hygiene.
Đây là một điều quan trọng.
The key takeaway for many of us will be to educate our patients as well as our healthcare personnel to wash our hands, wash our hands, wash our hands. If there is no visible soiling of your hand, you can use a 60% or higher alcohol hand rub, rubbing your hands with all surfaces involved for a minimum of 20 seconds. If there is visible soiling of your hands, 40 seconds is recommended with soap and water. If you were to have an opportunity or a patient were to encounter a cough or a sneeze, respiratory hygiene is covering your mouth with a bent elbow or a tissue and coughing into that. Anyone with respiratory symptoms should be asked and required to wear a mask.
Về hô hấp thì bắt buộc phải đeo khẩu trang.
PPE is the gear that healthcare personnel should wear whenever caring for a presumed or known COVID-19 patient. It involves a gown, an isolation gown, a face mask or respirator, with the N95 respirator being the most highly recommended, a face shield or goggles that also covers side exposure. Reading glasses or eyewear is not recommended. You need shielding on top of that, as well as gloves. This is just an interesting slide I encourage you to review later, showing the different personal protective equipment needs for our various healthcare personnel, including those that work amongst patients, those who clean our facilities, as well as those just visiting our patients. Second slide. Then in the laboratory or isolation areas, such as our front desk or our other interactions, these are suggested PPE recommendations. Go ahead. So to properly use PPE, go ahead. You want to put on all of your gear prior to entering the patient room. It is important to gather your gown, your gloves, your mask, and your eye shield prior, so you can put it on or don it in this order.
Và
You
chúng
will
ta sẽ phải có một
first
cái
perform hand
quy trình
hygiene,
mặc
such
những bộ
as
đồ bảo hộ này như
20
thế nào trong một
seconds
thứ tự nhất định
of
để bảo vệ cơ
hand
thể.
rub.
Trước
You'll
hết là
then
chúng ta
put
sẽ
on your
rửa tay,
isolation gown, which
sau
has
đó sẽ mặc
openings
áo bảo
in the
hộ vào.
back. All ties
Cái áo
should
này thì
be
sẽ có những
secured,
cái khoảng hở
and
phía sau để chúng ta
assistance
có
by
thể
additional
thắt nút
healthcare
vào.
personnel is
À,
sometimes necessary.
nhiều khi chúng ta cần
A face mask
nhờ một
should
người
have a
khác
strap
để
around
phát
the
hiện cái vết
crown
làm
of
sao
your
cho
head
chúng ta.
and a second strap around the base of your neck.
Sau đó là đeo mặt nạ.
Some masks have
Người
ear
95,
loops, and they
khẩu trang
should
người
hook
95.
accordingly.
Người
Then you
95
should
thường có hai
apply
cái
your
dây
goggles or your face
ở
shield.
phía dưới cổ
One
và phía trên đầu.
last time,
Nhiều
perform
khi là
your
có hai cái
20
tay
seconds of a
đeo vào từ hai
60%
tay.
or higher alcohol hand rub,
Sau
and
đó
then
thì
apply your
chúng ta
gloves
sẽ tiếp tục
with the
đeo
gloves covering
tấm
the
che mặt
cuff of
hoặc
your
là
isolation
kính.
gown.
Sau đó thì rửa tay một lần nữa và bước cuối
After
cùng
patient
thì
care is
đeo
completed,
găng tay.
at near the exit of the patient's room, but
Cái việc mà
still
cởi đồ
within
bảo
the
hộ ra
patient
thì
room,
phải
you can
làm
begin
theo
the
thứ tự.
doffing or removal of your
Ngay sau
PPE
khi chúng
gear.
ta đi ra
First, you will remove your gloves.
cách ly của bệnh nhân.
It is difficult to save these for
Trước
reuse.
hết
So the
là
recommendation is to
cởi
remove
găng tay.
and dispose of your
Thường
non-sterile
là găng tay
gloves.
sẽ rất là khó để mà có
At
thể
this
sử dụng lại,
time,
cho nên chúng tôi
within
khuyến
the
nghị là
patient room,
chúng ta chỉ có
you
thể
will reach your
tháo
gown
găng tay và
by
chúng
the
ta có thể đi
shoulders
luôn.
and pull or roll the
Cởi
gown
áo bảo
down
hộ
and away from you.
chúng ta sẽ
As there are many attempts to
dùng
reuse
cái
gowns, as
chúng
long
ta
as
sẽ bắt
you
đầu từ hai vai.
roll
Sau
the
đó thì cuốn
exterior
cái
surface upon
cái lớp
itself,
bảo vệ
you
xuống
can remove
và
it from the patient room
cứ như
and
thế
reuse
cởi ra
accordingly.
và để
You'll
vào cái
now
khử trùng để
step
có thể
out of the
sử dụng
patient
lại
room
nếu mà chúng ta
and
cần dùng.
perform 20 seconds of a 60% or higher
Sau
alcohol
đó thì
hand
chúng ta
rub.
sẽ rửa tay bằng dung dịch
You'll
cồn
have the
trong vòng
opportunity to
20
remove
giây.
your face shield by grabbing the
Sau đó
straps at
sẽ
the
đến
crown and behind your neck so you do not touch the front surface
cởi
of your face
cái mặt
shield
nạ
or
này xuống.
goggles. In a similar way, you will remove the
Chúng ta
straps
phải
of the
cởi một cách cẩn
respirator
thận làm
so that you
sao
do not touch
không
the front
chạm tay vào mặt.
surface of your face
Nếu
mask
như
or
cái tay
respirator.
đã chạm vào bề mặt
You
của
should
mặt
have a
cũng như là mặt
secured
nạ, cũng như
region
là
where you
cái
will
kính.
store these for if you are going to use continued use of the same face shield, respirators, and or gowns. And then after final removal and storage of these items, you'll complete your last
Và chúng ta
round
tùy vào cái
of
tình hình thì
hand
có thể
hygiene.
sử dụng lại những cái bộ đồ bảo hộ này sau khi đã
There's
khử
a
khuẩn.
video that is
khi mà chúng ta
available through
đã thử ra những
Parkland
bộ đồ bảo hộ
on
xong hết
YouTube
thì,
that if we have time, we can play closer to
bắt
the
đầu
end of our time
quay
here.
lại một
But
lần
it's a
nữa.
video just
Có 3 cái bước
illustrating
rửa
the
tay. Chúng
correct
tôi cũng có một cái
donning
video
or putting
hướng dẫn rất là
on
cụ
and
thể
doffing
là
or removal of your PPE.
sẽ mặc vào và cởi ra những cái bộ đồ bảo hộ này như thế nào, và nếu cuối buổi chúng ta có thời gian thì cùng xem.
It is important as a globe that we try and optimize the availability of our consumable resource, such as our personal protective equipment or PPE. We can do things such as using physical barriers, such as glass or plastic, where the patients first present. We need to be intentional to restrict the number of healthcare workers entering a room if they are not involved, in an effort to not overuse or over-consume our PPE resources. There's a recommendation to cancel any non-essential surgeries or procedures. There are also efforts being made for decontamination procedures using moist heat, hydrogen peroxide, vapor, or ultraviolet light. And these decontamination processes are being tested specifically for N95 respirators. And lastly, we need to think about restricting the number of visitors and the duration of their visits in an effort to optimize our our quantity of
cũng như là
available
những nhân viên y tế
PPE
nếu như
gear.
không chăm sóc trực tiếp cho người bệnh thì cũng không nên vào những cái khu vực cần
For
phải có
any
mặt.
reported case, you can visit
Đối
the
với việc báo cáo
WHO website,
thì
and there is a
thực ra chỉ có thể
WHO
vào trang
case
web của
reporting
Bộ Y
form,
tế
and the recommendation is that we
để
report all
những cái
known
mẫu báo cáo
COVID-19 cases
cho
within
COVID-19
48
cũng như
hours.
là báo cáo
Thank you so much, and I'll turn
trong vòng
this over to my
48 giờ.
colleague, Jose Laguna.
Bây giờ thì tôi sẽ nhường dân cho bạn y tá Jose Laguna là một
hello everybody, I hope you can
y
hear me.
tá từ ICU.
Yeah.
Có thể chia sẻ một chút về cái
Yes,
kinh
we
nghiệm của
can.
anh hiểu trong việc
Okay,
chăm sóc bệnh
so
nhân tại Tây Ban Nha.
thanks for this opportunity speaking about my experience here in Spain as a clinical specialist and ICU nurse now. So I'm an ICU nurse training background, and since many years ago I work as a clinical specialist for Masimo, and now I'm focused in training, especially in ICU settings. I've also worked several times in volunteer in Africa, so I know just a little about the healthcare systems in some not so developed countries. So in Masimo, I'm specialist in ICU monitoring. So I keep training and assessing different hospitals now. I mean, in this pandemic, how to assess adequate sedation levels with different drugs. Because one thing that is happening is that some hospitals are running out of the usual drugs they are using for anesthetizing. So they're starting to use drugs like ketamine, which are not used to. And there is a very high risk of over-sedating patients or under-sedating patients that have muscle relaxant. So that's so as for now, I went back to work as a nurse in a hospital in Madrid, in a COVID ICU in the heart of Spain's pandemic.
Hiện giờ thì tôi đang làm
I
việc ở
work
Madrid
full-time in the hospital and keep some of my duties as clinical specialist for Masimo, training healthcare professionals for its needs. So how are our statistics? Well, in Spain, as for yesterday, we have around 140,000 infected people, and 20,000 of them are healthcare workers. So that is our major problem. It's 14% of the total infected population are healthcare workers. So after a moment, we'll explain why this is. Hospitals in Madrid have almost duplicated their ICU beds with an average of 90% of ICU patients intubated, which means an average of 90 to 120 intubated patients in each of one of the big hospitals in Madrid. Patients that are incredibly unstable. So that's multiplying by 3 what we usually have in a hospital of intubated patients. So now healthcare staff, including me, we're not thinking if we are going to get infected, but we're more thinking is we are going to get infected, but we don't know when. So we're hoping to fall sick once the chaos has finished, not in the middle of it, for the sake of the patients and for the sake of us and our family. The problem is that the most needed assets, which is the healthcare workers, are the ones that we are more lacking of. And this destroys any contingency plan. You have many plans, but if a third of the assets turn on sick or in quarantine, then you're done for. So going back to our main topic, which is what mistakes did we make? I think I will start with not believing that this will happen to us. We saw it really far away, and we waited to do extreme measures until everything explodes, and then it's too late. We also thought that we had a wonderful healthcare system, so robust that nothing could beat us. We had enough staff, enough materials, enough beds, so we could cope with anything. We didn't do enough testing, early isolation, or preventive measures we're taking. And also one thing that I also highlight is that we were thinking that this only affects old people. So people below 60 years old were living without worries and note-taking. And this created a big issue in the ICU especially.
cho tất cả những cái phòng ICU có thể là
So we should be cautious and take measures before the blast arrives, because when chaos arrives, everything gets much more complicated, as happened in Spain and Italy. When chaos arrives, changes are more difficult to make. There is lack of adequate protection materials. We don't have enough stock of drugs. We don't have enough staff because we have more patients. We have much more critical patients. We have a relatively high number of the staff at home in quarantine or sick. And remaining doctors and nurses start working in areas that are not their specialty, like pediatricians, treating adults, dermatologists in emergency room. That's not the ideal situation. And there's a lack of protocols to follow. The system we used is trial and error. And those mistakes led to a lot of clinicians affected. Training is done in a hurry with live cases, so there's a lot of risk for the staff and for the patients. And all that is a risk for patients and for the healthcare providers in the hospital. So how it started here in Spain, it's like it started with very little cases in a few hospitals, especially Madrid. So a few the first days, which doubled the next day, which tripled the next day, and before the first week, the first patient, we saw that it was getting out of control. It was not a matter of weeks, it was a matter of days. So the first weeks were critical regarding hospital staff infection because there was no adequate protocol in place and staff was not properly trained in. So there was not enough protection material. So the assistance was not done with ideal protection and the people just didn't know how to use it. They didn't know when to put a mask, which type of mask, which PPE to put in each situation. So doctors were intubating without the proper equipment. Nurses were doing caregiving without the proper protection. So a week after the explosion, critical patients raised exponentially. So first we have a problem in the emergency room, the explosion of patients, not all critical, but just the first symptoms. And then a certain percentage of them got really sick. So what happened is we didn't have enough ICU beds. So we had to stop non-urgent surgeries and cancel them as there were no ICU beds available. Then the first healthcare staff started to show symptoms and put in quarantine. Emergency units started to overload, patients laying on the corridors, not enough beds at the hospital. We had a list of more than 100, some hospitals 150 or 200 patients waiting for a bed at the same time. Then critical patients continued to increase. Recovery rooms and operating rooms were made ICUs with extra ventilators and anesthesia machines. My ICU is 100% COVID patients. It's a recovery room made with ventilators and anesthesia machine, especially with anesthesia machines from the ORs. So we needed more technical staff. I mean, we multiplied by 2 the ICU beds, and we have only 2/3 of the staff. So we had to recruit a lot of people. We started taking specialties that were not typical intensivists, like pediatric intensivists jumped to adults. Last year, medicine students and nursing students were called to work. So we were actually realizing where we were in a very bad situation. We were doing a lot of treatment and proning. Proning is when you turn the patients upside down. We usually do this in respiratory distress patients. You don't have a lot of those patients usually in an ICU. I mean, you have 5, 10 in all the hospital in an ICU, but now we have 90 to 120 patients needing proning and very close contact with them. And that's very difficult and dangerous. To prone a patient takes around 4 to 5 people at least, all well covered with PPE. Also, a problem we had is that we have many ICUs in the hospital, and each one was doing a different treatment protocol until one day they decided to stop this. So they say, okay, we have a big issue. Many people are not intensivists, many people are not emergency doctors. we shall make it simple. People are jumping in without knowing these type of medicine. So let's do all the same protocol. So now all the patients have the same protocol. So you jump in any area of the hospital, you know the treatments that they're doing. Same for ICU, all patients the same sedation, antibiotics, hemodynamic drugs, ventilation criteria, with small differences depending on particular situations, but we try to make it as simple as possible. Nurses, we have a list of different drug site dilution everywhere to avoid accidents, because that's also typical, because less than half of the nurses were not working in ICU before, or some never worked in ICU ever. Or for example, like me, I've not been working directly as a nurse in an ICU for 10 years, so it's not easy to get back to all that. So mistakes were happening. There were also some specialties like surgeons that they did not know how to help because of not operating rooms working, just such emergency situations. So what we did is train them to prone patients. So we had surgeons trained to prone patients, and we have 24 hours them available to prone patients. So we discharge a little bit of the overload of the nurses and doctors on each unit by bringing 4 or 5 surgeons well equipped and perfectly synchronized to change patient positions, which makes it much safer. And also we made doctors that their specialty was not really practical in this situation to be useful. We need hands. Hands is very useful. So also in Madrid, we opened free hotels for the clinical staff that we recruited from all the country, like me. But what shocked me more the first day I entered the ICU was that 90% of the patients had between 35 and 55 years old. They were not the old people that I heard that were most affected. This is because most of the older people die at home or in retirement homes. And due to the lack of ICU beds, older people are not being intubated. They die in the emergency unit or at the wards. Doctors have to decide who to admit in the ICU and who will unfortunately die. So now in Spain, we have installed a severe self-isolation measures for the population. We have also opened hospitals in Congress halls to take out of the existing hospitals the COVID patients. It's like now they are infected hospitals. We want to try to make them clean hospitals again, taking the most of infected patients out of the hospitals. We should have done this before. We have opened hotels where to quarantine infected patients with mild symptoms. Now we have less pressure. We can see the results. We have less pressure in the emergency room. So it's still overloaded, but now not critically overloaded. But in the ICUs, they are still full now. Having less pressure in an ICU does not mean that there are free beds. It means that the intubation threshold has raised. As when I started, the first day, we were usually not intubating above 60 years old. Then it passed to 65. Now we are in 60. So for us, the pressure is not, we don't have patients, we have free beds. No. It means we can intubate more patients or older patients than before. And there is still a long waiting list to enter the ICU. Also, a big problem that we have with COVID patients is that they require 2 to 3 weeks of ICU. That blocks the ICU for a long time. Really blocks it. They are very unstable patients. They're young and healthy adults that desaturate severely in a matter of seconds, and it's complicated to recover them. They're very unstable. And we don't know what the patients that survive, young people, hope it's most of them, we don't know the sequels, the problems that will have the rest of their lives with the situation, something also unknown. So the ICUs still have a lot of work to do, even though infections and hospital admissions go down. This will take a few months.
cái tốc độ lây nhiễm giảm xuống.
One thing that we're trying to
Như
do
là
now
lên nhập viện giảm,
try to generalize COVID
làm thế
testing
nào để
because
chữa
we have
thật
done
bệnh
very,
nhân
very little.
vẫn đang ở trong
And now
ICU
we'll try to
có thời gian
concentrate
3
as I
tuần.
said, COVID
Nó
patients
sẽ là phức
out
tạp.
of the existing hospitals into hospitals built by the army or Congress centers. So if all this is happening in a developed countries with a good healthcare system, what will happen in a not so developed country? I mean, you don't have ICUs in not developed countries like here. So
Đối với
yeah,
những
those
quốc
patients
gia
that we
mà kém phát
intubate
triển
with
hơn thì
35,
không có
40,
cái ICU
55
như là Tây Ban
patients
Nha
in these
thì làm như thế
countries,
nào?
you will not be able to intubate them in not developed countries. So it will
Thì
not be a pandemic
ống
for the elder, it will be a pandemic for the adults in
nội
general.
khí quản cũng là cả một vấn đề.
When healthcare system is minimal, prevention is the cheapest and most practical solution. So if the
Thì
healthcare
đối với
system
những
cannot cope
cái
with
quốc
this,
gia này
with
theo
all
tôi
these ICU
là
settings,
cái
all this
việc
material,
phòng chống
the efforts must be
cách
taken to
tiết
stop
kiệm
this
nhất,
before a great spread.
làm
So
sao
we're assuming
để
this
có
in,
thể
take it
phòng bệnh
seriously.
trước khi
It's
mà
better
lan
and
rộng ra
cheaper
cộng đồng.
to
Không dừng
overreact
những
in
trường
the
hợp
beginning than wait until everything explodes. Have logistics ready for when this arrives. Have COVID
đại dịch
hospitals
này
ready
bùng nổ như ở Tây Ban
to
Nha.
avoid infecting existing hospitals. Have protocols in place according to a realistic list of materials and staff available.
Làm thế nào để có thể chuẩn
And
bị tất cả
train
những
staff before
đồ bảo hộ,
chaos arrives to reduce risk.
tìm được đủ người, có đủ trang thiết
So
bị,
with all
cũng như là
that,
đủ thuốc trong cái
that's
khoảng
all
thời gian
that
chuẩn
I
bị
can
khi
say.
mà
So
bệnh có thể lây lan.
thank you. I
Rất là quan trọng.
pass it to you.
Vâng, đấy là cuối của những cái chia
Thank
sẻ
you so
của tôi.
much. That was really great. We appreciate both of you guys giving your time and giving
Vâng,
us
rất là cảm
these
ơn cả hai chị đã
presentations.
chia sẻ.
So at this point, we would like to open it up to question and answers. If you have a question for either
Bây giờ thì chúng tôi sẽ
Jose
có
or
cái
Bridget,
phần
please
câu hỏi
feel free to ask
Bridget
them
cũng như là
now.
Jose.
You're also able to ask them in the chat function if you
Nếu như
would
các anh chị
prefer.
không muốn hỏi trực tiếp thì có thể đánh vào cái phần chat box.
And Chase, we also have a list of questions from each participant during the course of their registration. So we are available to answer those if questions don't come up here today.
Những thành viên trong cái buổi hôm nay đăng ký thì cũng có thể trả lời những câu hỏi đó.
Well, if no one has any questions, we can start going through that list.
Jose, I'm going to invite you to please join me for any additional comments for these questions. Some of the questions we touched on in our presentations, but others may have been left lacking. There was a question as to whether there are any vaccinations currently available in any country. And to date, there is no vaccination. There are several candidates being studied. One is using a messenger RNA to get a viral protein spike to then elicit an immune response for a patient, but it is not yet available in any country. People were asking about how, and Jose referred to this, how to set our priorities and develop a response in a developing country context. As some of you may know, I am a physician that was trained and born in the United States, but I lived and practiced in Uganda, Africa for 6 years. So my colleagues and I from Uganda have been in close communication. And even with our efforts in the United States and Spain, this is something that we can all share and learn from each other. Again, the key to the prevention of transmission is home isolation
cái chuyện là
and
tự cách ly tại
avoiding
nhà,
large crowd gatherings.
tránh
So I know
tập
for
đông,
Uganda and many other
là giãn cách xã hội ạ.
countries, schools have all been closed.
Trong ở rất nhiều
Churches
quốc
have
gia,
been
toàn bộ các nhà thờ, các trường học đều đã
found to be illegal to gather. And the
có
main
những
form
cái biện pháp mạnh mẽ từ
of
chính phủ để
transportation
chống những cái
for
hiện
many
tượng này.
developing countries are the motos or motorcycles, as well as bus transportation or taxis. And these have all been declared illegal, and you are not allowed to offer or participate in public transportation in an effort to stop the COVID pandemic. For Uganda specifically, you can get a government-issued approval to have a essential travel approved, but this has been few and far between. I think the key is hand washing. Even with our contaminated water sources, we know that the physical action of rubbing our hands together helps to decontaminate soilage, and so we use whatever soap we have available and water source.
Vô cùng quan trọng, việc rửa tay vô cùng quan trọng.
Other questions? I'll first see if there's any here on the portal, or Jose, if you have anything else you'd like to add.
It's Monica here. Just wanted to jump in. One just came in specifically for Jose, if I could just read this out, because I'm not sure, Jose, if you're seeing it. Nicholas from Malaysia asked, if the private healthcare sector, did they join in to help out the public healthcare sector in Spain in order to help alleviate the crisis of patients over flooding the hospitals? If yes, how did they help and in what proportions?
Hi. So in Spain, we have a very peculiar healthcare system because each region is divided in 17 regions. So each region has the ability to control their healthcare system, and this doesn't help too much. 17 different ways of acting. So the government tried to control all that, and the region in Madrid took it's not taking power, but took the supervision of also private hospitals. Spain is mostly public. We don't have so many private. We have a lot, but mainly public. So all the private assets went to jump and be supervised by public hospitals. So public hospitals, the regional government has the authority to take patients there. And they were always doing it. They were always admitting patients with COVID or intubating patients, having their ICUs with patients with COVID. So yes, I mean, it's something that we did. Some people say that not enough. We should have been done more, but yeah, that's something that we did since the beginning. So there's another one. Why do you think most of the people infected and severely affected are 35 to 40 years old in the hospitals? It's not that they are the most affected, as the older people that are affected are not intubated. 60, 70 years old in Madrid were not intubated. In other areas in Spain, for example, in east or south, we intubate without restriction because there are still free ICU beds. The problem is when they're all localized in Madrid in one area. So it's like a big explosion in one area. So you just intubate the severe ones between 35 and 55-year-olds. It's major population that we have because we don't intubate so older people. That was the most saddest part of it. And we didn't think that this would affect so severely to young patients. But you have young and healthy patients in critical condition, and not all have hypertension. Some people say, yeah, but I mean, 50-year-old, he has problems, health problems. What type of problems? Mild hypertension. I mean, who doesn't have mild hypertension above 50 years old? I mean, or overweight with 50 years old. I mean, that's most of the population. Thanks.
Yeah, that's, go ahead.
I was just going to add one more question to Jose and then a few directly to Bridget. Jose, another question that came in, how can we implement a selective strategic quarantine lockdown in a country or a local community?
Làm thế nào để có những cái biện pháp cách ly?
Selective quarantine. So, first of all, you need to know who is infected.
Thứ nhất là chúng ta sẽ phải biết ai là người bị lây nhiễm.
Because you have to select, you need to know how many people are affected. So we have done that, but as we have not tested so many patients, we were one of the countries that has tested the least, unfortunately.
Tây Ban Nha thì rất là không
but
may.
The ones that we have tested, so you're tested. If you had mild symptoms, you go to a hotel. Specific hotels that are medicalized. They have doctors, they have nurses, and they implemented a system how to take care of it. You have bigger problems, then we try to go to one of the new hospitals that were made in the Congress centers to avoid taking them to existing hospitals. And the most severe cases go to the normal hospitals that we know. But for that, first of all, you need to do a massive testing. Without that, you cannot select. That's what's happening to us. We've done so little tests. We don't know really how many people.
Tôi lại phải nhắc lại một điều nữa, đấy là xét nghiệm.
We cannot do that.
Vì nếu như không xét nghiệm thì cũng không thể biết
quarantine selection.
Ai là
the first thing is
vì thế nên cũng không thể có những cái biện pháp cách ly một cách hiệu quả được. Tây Ban Nha thì đã không làm đủ xét nghiệm. Thì đang cố gắng.
Bridget, for you, really, this is to either of you. I'm just ping-ponging back and forth, but two questions. From what you know, what is the survival rate of those with comorbidity? And can you provide any estimates for how much of the world's population might become infected?
Yeah, in the chat feed, I tried to address some of these questions. So the survival rate for COVID positive patients with comorbidity is a tricky question. For hospitalized patients, we know that about 1/3 are going to require ICU admission for respiratory support, with 4 to 10% of those requiring intubation. And Jose was able to offer a lot of insight into that. While I don't know the survival rate, that you can look at what we've seen for hospitalized patients. The case fatality is currently as high as 11 to 15%. But again, this is for hospitalized patients. So we're going to have a higher level of survival for our mild cases that are not hospitalized. And then I saw the question of how the prediction of the estimates of how much of the world's population might become infected. I'm going to defer to Jose. I have seen lots of statisticians and epidemiologists. I just don't know if I know who's right. So maybe Jose or Vaughn, if either of you have a more educated answer, I'll defer to you guys.
We calculate that the real infected people is 10 times more than what we test. That's what we think. And regarding the survival rate, for example, the ICU where I am, the recovery room, it's a 15-bed recovery room made COVID ICU. It's not the one with the best numbers, unfortunately, because we receive very severe patients. In the hospital, we receive the most severe patients. So last week, 15 beds, 5 patients died, 2 patients went out extubated. So the ratio is not nice. I wouldn't, it's usually could be half and half in ICU, severe patients intubated, but we still don't know because people take so long in the ICU. We still have to see how is the evolution. It will take a little time to know exactly the survival ratio. It's too early.
Okay, thank you. I have 2 questions here from Indonesia. Jose, the first one's for you. Other than comorbidities, in terms of death factor, what are other factors that were found related to
Ngoài
high
những cái
COVID-19
bệnh
patient
đồng mức ra
mortality
thì
in
còn
Spain?
những cái yếu tố nguy cơ nào dẫn đến tử vong của những bệnh nhân đã nhìn thấy ở trong phòng ICU ạ?
First of all, we have a high rate of old people in Spain. We have a very old population,
Trước hết là cái dân
and
số
we are
già
a
ở Tây Ban
very
Nha rất là
sociable
nhiều.
People, so we spread it
Và
very
Tây Ban Nha
fast.
thì là một quốc gia rất
So
là
that was a
có những cái hoạt động
major
xã
issue,
hội rất là
and that
tưng
we
bừng.
got overloaded
Thích tụ tập,
very
rất
soon
là
in the
thích đám đông,
ICUs.
thích ăn uống
So
cùng với
we were
nhau nhiều
already
nữa.
like in the limit without any problems. We were already saying we need more ICUs in Spain last year. I mean, without any issues. So we were just at the tip of the edge, and this jumps in. Then you have to choose, and you just
khi mà
cannot
có một cái
intubate
bệnh
them.
truyền nhiễm như thế này
So we
thì
have a lot of mortality,
rất là
especially
khó
because
khăn.
we cannot treat all of them. And
Rất là
most
nhiều
of them
phòng
are
ICU.
old people that never got to the hospital. For example, died at home, died in the
Và rất là không may là có nhiều người già ở Tây Ban Nha
the residence for old people,
tuổi
the
tác của họ
retire homes.
như là cái điều kiện cho nên
The
họ
big
mất
issue
ở nhà.
that this is happening and that we are seeing that really scares us is that there's a moment where this makes click in the body. So you have mild symptoms, and then suddenly you can go good, or in hours you cannot be able to breathe. So we have found in the hospitals people dead in the rooms after the nurse passed 1 hour before to see the patient. Patients, my wife works in an ambulance, and she goes to the
ví dụ như là vợ tôi làm việc trong xe cấp cứu,
to the homes, people homes, and when they get there, some people are already dead in the corridor. They were walking. It's like there's a switch from going well to go really bad. It's like Boris Johnson. He went from home to the hospital and immediately to the ICU. Not like, hey, I'm okay, a little bit worse, and then a few days I'm a little bit worse. No. It's like, I'm not too bad, and if I'm young, I'm going to resist a little bit. I don't want to go to the hospital just in case something happens or I get infected. And then in a few hours, you go from 0 to 100. And it's really complicated. And if you don't have immediate treatment, I mean, you can't do anything.
Thank you. Bridget, another question from Indonesia for you. There's concern that this virus is transmitted from an airborne perspective, and you kind of touched on this in your presentation, but according to the WHO, airborne transmission occurs only in hospital settings or primarily in hospital settings. Can you elaborate on your thoughts on this?
Yes, that's a great question. I saw it here. And it's a tricky one. Even in the course of preparing this presentation, I changed my answer. We know there is droplet transmission, and think of that as a vehicle of secretion that can physically fall to the floor. We know there is contact transmission, and see that as touching an infected surface, and it's thought to be infectious up to 6 to 9 days off of an infected surface without disinfection. And I initially said airborne was still being studied, but with the asymptomatic transmission and with the high level of healthcare workers having positive COVID conversion, even with PPE, there's now speculation that there has to be, or there is a strong suspicion to have airborne transmission as part of this virus vector of transmission.
And another one here, Bridget, for you from Papua New Guinea. Is it true that the COVID-19 virus is continuously mutating and that it makes it challenging to come up with a vaccine?
You know, it's interesting. I heard someone else ask me that, and there are strains of viruses that are very smart and like to mutate. The corona RNA viruses, I don't know to be a rapidly mutating viral strain, But again,
thì đây
Jose
không phải là một
or
chủng
even
virus
Vaughn,
quá là mới
if
nữa
you've
ạ.
heard different, I've heard that as a speculation. That does not seem to be a challenge that I am aware of for this pandemic, but please
Cho nên là
correct
cái
me
việc
if
phát triển
I'm wrong.
vaccine thì thật ra tôi
Yeah,
chưa được biết
from
là
my
có
side,
một cái chuyện
I
quá là
haven't
lớn.
heard that. I heard that it was going to be feasible to have a vaccine. So, but I cannot say more. I'm not an expert in that.
Vâng, cái này thì tôi cũng không chắc chắn.
Jose, another question to you. Do you think is it better if the ICU only takes in older patients and patients with immunocompromised conditions? It's a question from Indonesia, where I guess a lot of people are coming in to get tested for COVID to the ICU, younger people, including children, and should there be kind of that separation between them?
That's going to depend on the facilities you have, the assets you have. So the ideal situation is that you have so many beds that you take to the ICU everybody that you can, that you want. The situation, this is a war zone. Doctors have to decide who have the most chances of survival. So if you have to choose, like is happening today, 2 patients die, you have 2 ICU beds free, who are you going to put in? The 50-year-old patient that has no comorbidities, or the patient that has immunosuppression problems, cancer problems, that will most probably die even with all the efforts. So it's who will survive most, the one that's going to have that place in the ICU. In other places of Spain, we don't have that situation. Everybody can get intubated because they don't almost have a ICU patient. They all have, but not as severe as us. But when you have to choose the one that has a bigger survival rate, and it's not easy to do that, to take that decision.
Chuyện này thì các anh các chị có thể tưởng tượng là không dễ một chút nào ạ. Nhưng mà cuối cùng,
this is a question I'm going to pose to both of you. It's from Singapore, from an epidemiological perspective, because how do the lockdown measures end? Understanding that South Korea and China have significantly reduced the number of new daily cases, but they're struggling to lift these measures. So what are the kind of next steps or progression of events that would enable the end of a lockdown, in your opinion?
Cái yếu tố nào quyết định cái chuyện ngừng lệnh phong tỏa, thưa các anh chị?
Did you have something, Jose? Oh, sorry.
Not an easy question.
Yeah, I think that's the beauty of a consortium like such as ours. Lockdown has many implications, as we're seeing in our economies, in our educational systems, and then as Jose referred to, in our healthcare. I'm currently at home on quarantine because I was exposed to a patient who lied about his symptoms to attend his wife's birth. So a presumed COVID positive who confabulated. So it's not if we're going to get these infections, it's when. And so then how do you project the removal or the reversal of our lockdown? Most viral illnesses, and we look at the family of this virus with other coronavirus illnesses, have a life cycle. And so we are, again, the incubation period and the symptomatology is often a 14-day window. So we're hoping to use some of that data to project ahead while limiting the continuation of transmission, because sooner than later we need to talk about lifting these isolations on an academic and educational means alone. But China has due concern, because as soon as they open, if they have a infected expat enter their country, then there is concern. We have seen some studies with convalescent plasma infusion, where those with infection can then offer plasma to those who are not yet infected. We're also looking at, once you are infected, is there a protective immunity and how long does that last? So some of those factors will aid in this protection of people beyond a vaccine or something that might not be as immediately available.
And speaking of vaccines, is there any chance that the 18-month timeline for development of a vaccine can be shortened?
Vâng, và lại đề cập đến cái vấn đề vaccine ạ. Vậy thì liệu rằng
again, I know that there are numerous drug trials going on, and there are numerous, like I said, decontamination techniques. Vaccines, unfortunately, are a slower process, just molecularly. So I think all hands on board globally are invested in facilitating that process. I know large financial representatives worldwide are offering financial assistance, but I don't know the time frame that it's reasonable for a vaccination development. So if someone has heard 14 months is the minimum, it may just be the vaccine process. I'm unaware.
Jose, I'll ask this question to you. How can countries or hospitals handle the massive test requirements and the global shortage of diagnostics and extraction reagents?
I mean, our experience in Spain is that we're not handling it well. I mean, if you don't have massive tests, you just have to think that most of the people are infected and treat everybody that you don't know as an infected person. So now everybody's saying that you should wear a mask just in case. So you must treat everybody as if they had the virus. So not touch them, not be close to them. If you talk to them, cover your mouth, have a mask. So that's the only way. So massive tests, how not doing yet a massive test, but the best thing is to doing in some cities is go to each block of buildings and have the people go one by one down being tested, or people that can drive go to a parking lot and get there tested one by one with a previous schedule. But we're not a good experience of massive testing, so I don't know how this should be
done. And another question for you, Jose. Actually, questions coming in from nurses specifically. Besides PPE, is there anything in particular that you can prepare for? For example, any special nutrition in Spain to enhance immunity, or anything else that you're doing to help prevent against COVID?
Well, something that's interesting in these COVID patients, I didn't say before, but when I entered the ICU, first time, I was shocked because in my ICU was 80% were men. I'm a man. Most of them between 35 and 55. I have 42. Most of them have, if not all, overweight, which I have. So it's like, okay, I have a lot of possibilities there. So we heard about vitamin C and vitamin D, but you have to be realistic. So you are going to you're going to fight better against any disease if your health is better. And nutrition is important. So since 2 weeks ago when I started working, I do take care, and most of my colleagues take care of what you eat. Less carbohydrates, more vitamins, more fruit, more vegetable, fish, meat, variety. We try to do exercise. I lost 5 kilos in 2 weeks doing exercise. I mean, take this seriously, because when you see what's happening, because obese patients in ICUs with respiratory distress are really complicated. All that volume pushing the lungs inside, when you have lung problems, make it very difficult to manage.
bật hoạt hơi của miền Pành su.
Sorry. Không nghe thấy gì ạ?
Jose, go ahead. I think we had a small technical difficulty there.
Okay, so yeah, I mean, it's nothing that has been said in public, so you have to do that, but it's the logical thing, and I will tell my friends and my family, keep healthy, stay healthy, and start being healthy, because some people say, yeah, there was a lack, like in Italy, you know, they say there's a lack of vitamin D. So okay, eat more blue fish, take a sunbath if possible. Now in quarantine is difficult, but take care of your nutrition. Try to be a little bit more healthy than yesterday. So if it jumps in, you have a little bit more, your body's a little bit better prepared for the situation. It's not good to do anything bad. So for me, already lost 5 kilos. Let's see how much I'm able to lose.
Thank you. Bridget, over to you. Someone is asking if animals can get COVID, and I know there was recently I think a positive case at the Bronx Zoo of a tiger, in my understanding. If yes, is there a chance of zoonotonic, I'm not sure if I'm saying that correctly, apologies, transmission to humans?
Because the first case of patients in Wuhan, China was with this seafood and live animal market, there's already been suspicion for possible animal to human transmission. So I think that is possible. And for some of the home isolation recommendations for a positive COVID patient, there's been recommendations to wear a mask in your home, and that's not just to protect fellow family members, but also to protect animals in the home.
And another question for you, Bridget. Another one about vaccines. Can we develop vaccines from people that have recovered from the infection with antibodies against COVID, i.e. passive immunity, to help in prevention and treatment?
So there have been some studies that it is using the plasma of recovered patients who have COVID-19 antibodies, and through the transfusion then of this plasma to study subjects, we're looking at what can be benefited from that. If there can be a delay in disease, if there can be a passive immunity, so that is being studied.
Để xem là cái cơ chế miễn dịch nó có sản sinh ra cái
Okay, great. And this is to either of you. You touched about it in your presentations, but what has been found related to the management of COVID patients in hospital that could significantly improve their chances of reducing the high mortality rate of these patients?
Phương pháp nào đã tỏ ra là có hiệu quả nhất ạ?
Well, for example, from my side, something that we could help in is detecting before when that big deterioration jumps in. So that's something, for example, now at Masimo we're doing is try to monitor patients at home or at the hospital with wireless pulse oximeters to alert when that thing, when really it blasts in your body. Because sometimes you don't have time to react. So monitoring patients will help a lot. Centralizing the monitoring will help a lot to detect when that happens. And also have a lot of ICU beds ready, so you don't have to choose who to intubate. So test a lot of people, monitor patients if possible, as most patients as possible, to see deterioration as soon as possible, and have ICU beds ready.
Yes, I'd agree. There's a study out of New York that had a high level of COVID-19 infection rates, and there were some obstetrical young late 20, early 30 patients that presented asymptomatically for just routine delivery at 37 weeks. And one was undergoing cesarean section, again, was asymptomatic and had significant blood loss at time of her cesarean section, so was intubated for obstetrical reasons and immediately went into respiratory distress and had a full-blown event of severe acute distress. The second patient, after a successful vaginal delivery on her second postpartum day, was being reviewed with the nurse for discharge and suddenly became cyanotic and short of breath and was found to be COVID positive. So I think the key is high clinical suspicion. I have an 80-year-old patient intubated now. She has a lot of comorbidities, being a cancer survivor as well as elderly, and she has been entered into 2 different clinical trials. She was given the remdesivir, which is a nucleotide analog drug under investigation, and she was also given hydroxy chloroquine. And as Jose mentioned, the difficulty with COVID is how long these patients are being hospitalized in the ICU, and it's kind of stalling our ICU availability, as she's been intubated now for 4 weeks with low probability that her case may come out without fatality, but we're still hoping and believing and praying.
Rất là trẻ, chúng tôi đang điều trị, nhưng vì cái thời gian mà phát hiện tệ hơn của bệnh nhân về mặt lâm sàng.
What do we know about the quality of the SARS-CoV-2 test kits that WHO has at the moment? This questioner is asking, we've heard the test kits from China, their accuracy is only about 30%.
Hiện giờ thì đã có những cái lo ngại về những cái xét nghiệm, đúng không ạ? Có một bộ xét nghiệm đến từ Trung Quốc hiện giờ là cái tỷ lệ chính xác của nó.
So I'm unsure if that is, if it's the PCR assay, it has a high sensitivity. I think the last time I peeked, there's a lot of numbers I'm jumbling in my head. I think it was like 99.8 or 98.9, so very high sensitivity. There are some serology tests that are being investigated for IgG and IgM antibodies. I'm not sure which test kits we're referring to with the WHO specifically.
Nhưng tôi không biết là các anh các chị đang định hỏi cái xét nghiệm nào.
There would be decreased sensitivity for a serology test, because antibody tests can show prior infection, and even there's suspicion that it could show a previous coronavirus infection not specific to COVID-19.
Vâng, tất nhiên là những cái xét nghiệm kháng thể này thì có thể xuất hiện dương tính nếu như bệnh nhân đã
Jose, I wanted to pose another question to you, and I know we are running out of time shortly, but just a few final questions. What is the best strategy for prevention of infections among healthcare workers or nurses in a situation that inadequate PPE is available? Or that it's not available, I guess I should say.
Distance. Stay away of infected patients. I mean, it's the only thing you can do. Stay. And also some mistakes that we were doing is we protect ourselves. We treated patients as if they were infected, but we did not treat our colleagues as if they were infected. So in the hospital, you can see sometimes a too relaxed situation between healthcare workers,
Vâng, và có một cái lỗi
is
mà mọi người hay mắc
completely
phải
the
là
opposite
chúng ta
of
không coi
what
những
we
đồng nghiệp của
recommend
chúng ta
outside,
là
I mean,
những
to
người có khả
everybody.
năng mắc bệnh.
So in the
Là
hospital facilities,
đối
we
với bệnh nhân
should
thì chúng
also
ta
be
thường là cảnh giác
very
hơn về
cautious
sự lây nhiễm, nhưng mà
between
đối
us,
với những đồng nghiệp
because you can see that doctors speak to
với
themselves
nhau
without a mask sometimes. They
sẽ
say,
không
hey, no, that's not right.
không
So we
đeo
should
khẩu
also
trang khi
think
nói
that our
chuyện
colleagues are infected,
với
and
đồng
that's
nghiệp của
something
mình.
that we
Đấy cũng là
should
một
change. Sometimes
sai
we
lầm
get a little bit
mà
relaxed
hay
with
mắc
our
phải.
colleagues and our partners.
Vâng, cho nên là sẽ phải coi tất cả mọi người.
Okay. And also, Jose, just two more quick questions to you that I've noticed that came up in the pre-questions. What is the effectiveness, if you're aware, of a disinfectant box or tunnel at the entrance to a hospital building? And what are the important aspects of medical waste management for COVID?
Okay, so regarding the first question, in one of the hospitals that the Army did in a Congress Center, they implemented this possibility of disinfecting before and after going out. But the problem is that disinfection has to be with the PPE. So it was because they had PP3, I mean, really good PPE devices that you could spread with water and complete fast liquids.
Nhưng mà ở cái bệnh viện đó thì họ có một cái hệ thống khử khuẩn rất là tốt ạ.
I mean, our gowns, what we use, you cannot spray it like that, and the mask cannot get sprayed like that. So it looks ideal, but they had to take it out because it was not practical. And you don't put on a PPE, a complete PPE, enter the hospital, stay there 12 hours, and then go out and take it out. You put the PPE when you go to get in contact with a patient. So you can do that in each of the areas of the hospital. So you have to, that has to be reasonable. Could be done if you have a big ICU, like in a Congress Center with a lot of space, then you gear up, you discontaminate, you go in, then you go out. But if you're able to do that in a big place, that would be perfect. If you have the PPEs that can be disinfected that way, that would be ideal. The thing is that we, for example, we don't have it and we have to take it out. But if you have it, it will be a good solution. And what was the second question?
Liên tục như vậy thì vẫn là tốt nhất, nếu có được cái điều kiện làm như vậy thì tốt nhất.
Well, it was about the medical waste management.
Yeah, so we have so we just have a different type of buckets. So how we treat the waste, where there is the infected waste and the not so infected waste. So because we think that everything is infected. So the inside, so everything that passes 2 meters close to the bed is infected and goes to a different bag. Everything that is out of those 2 meters is just considered dirty, but also with caution. So you do also always with double bags. So one dirty bag, you put it inside a clean bag, so everybody that touches the last bag doesn't get infected with that one. So I don't know exactly how the hospital has done outside, of the area, how it's done, but the major measures are inside. So everything that goes out has to be in double or triple layers, so nobody out gets infected. So that's the most important thing. Everything will.
Tiêu chuẩn là chứa vào những cái thùng có 3 lớp lót.
And I do want to end off. I do have one last question, and this is the first part is to Bridget, but then the second part is to both of you. Just a quick answer from Bridget, if you're aware, is it true that a warmer climate does help reduce or prevent the proliferation of COVID infections? And then a question to both of you that is really relevant for this cause, what is the most pressing need or focus that the Southeast Asia community should be focused on right now in terms of prevention of COVID?
Đông Nam Á trong cái đại dịch này.
Great questions, and I apologize. I saw the warmer climate question on the registrations, and I have not confirmed my resources, but viruses are tricky, and again, this one is a transmission is very dependent on proximity, so warmer climates can lead to more interaction in a non-home isolation situation. So I think studies that I've seen comparing virology of cold or warm versus cold climates has some control issues. It has some bias that I'm not able to tease out. So for what I have read, there's not a strong association or concern for enhanced proliferation in warmer climates, but I'll defer to Jose or anyone if they've read that, because I've not confirmed that specific to COVID.
Yeah, so that's interesting. In Europe, the warmer countries are Spain and Italy, where they're most affected. We don't have so many cases in Norway, in Sweden. Usually it's because of what doctor said, that we are very sociable, we go out, we get a lot of interaction. In Germany, they said don't move, and they didn't move. No social interaction. Not that they had a lot before, as we have in Spain and Italy, but they reduced it drastically. We didn't. So I think there's more, as doctor said, more social interaction than weather. I mean, Spain and Italy have very good weather, and we are struggling with it.
For the second question, what's the most pressing need for Southeast Asia right now? I think for the sake of not sounding like a broken record, I appreciate Jose's summary of, we should assume everyone is positive. 81% of cases are going to have mild presentation. There's a subset of patients that are going to have asymptomatic presentations. So we should be wearing masks at all times. We should sustain 6 feet or 2 meters social distancing at all times. In Southeast Asia, we have to be careful with our crowded transportation systems. We have to be very intentional with our patient triaging, using physical barriers such as glass or plastic with initial patient presentations to healthcare facilities. And we need to be resourceful with PPE, making fabric, homemade cloth masks for the general population, and being as resourceful as we can with the hospital grade PPE resources we have available to us at all your facilities there in Southeast Asia. Jose?
Yeah, I think that's, I completely agree with that. Yeah, exactly. I have nothing to add that. Yeah.
Okay, great. Thank you both so much. I'm going to pass this along to Chase now. We are going to wrap up this call because we're over time. But Chase has some housekeeping and ways that we can all continue to connect after this.
Yeah, thank you. I'd like to thank Dr. Bridget and Jose both for putting on these presentations. They were very informative, and I think everybody got a lot out of them. I'd like to thank our interpreters as well for helping make this possible and helping people get the most understanding that they can. We didn't have time to play the PPE video on how to put them on and take them off, but we will be making a link available to everybody, not only to see that video, but to the presentation itself, as well as a recording of this session, so that you can watch it again on your own time. We're going to be doing these weekly, so we'll be sending out another invitation to all of you very shortly, and in that we'll tell you again the time and what the topics will be. And so please, everybody, when you receive that invitation, feel free to send that on to your colleagues or anyone else that you know that may be interested in attending these and learning from people who have been there and ways to improve the care in your facilities. Thank you all for coming out, and we will see you all again next week.
Và xin hẹn gặp lại mọi người vào tuần tới ạ.
Thank you.